Welcome to Fire Engineering's Training Minutes. I'm Mike McEvoy. Today I'm going to talk about some tips for needle decompression of the chest. So the thought about needle decompression has changed a little bit over the years, and we understand a few things from CAT scans that have been done on military fatalities. One of the lessons that we've learned several years ago is that the depth of the needle is very important to success of needle decompression. The placement of the needle and how you place it also has a lot to do with whether you're going to need to needle the chest a second time or a third time. So the needles that we carried for many years were 14-gauge angiocatheters that were less than 2 inches long. Studies with CAT scans on military fatalities has discovered that the average depth of the chest when you're decompressing in the anterior chest wall is somewhere around 5.36 centimeters, which means 2.1 inches deep. That requires us to carry, according to the researchers who conducted this study, a needle that's 3¼ inches long. So the current thought process for carrying those sort of needles is to use something similar to the trauma needles that come from the North American rescue folks. And they've made a case that actually holds this, which is one of the problems when you're carrying a very long angiocatheter that you infrequently use, is damage to that catheter. This is in a rigid, solid case, and it's a 3¼ inch 14-gauge needle. So the two spots that we would locate the needle typically are first to needle the anterior chest, and then if that doesn't succeed, or if there's difficulty with doing that, to needle the lateral chest wall. So indications for doing a needle decompression are now twofold. You have a patient who has chest trauma that you suspect has some sort of collapse of the lung or blood collecting in the lung cavity, or perhaps you have a patient who has chest trauma and is in cardiopulmonary arrest. If you had a patient just with chest trauma and you suspected a pneumothorax, you'd needle the side where the injury occurred on the patient. If you had a patient who was in cardiopulmonary arrest from chest trauma, you'd bilaterally needle the chest. In other words, you'd needle both sides of the chest. So, a couple things about this process. Number one, if the patient had a seal, some sort of a chest seal on them because they had an open wound on their chest, and you are having difficulty ventilating the patient, or you're having problems with the patient's saturations, you'd burp the seal, try to get some air out of the chest. You want to monitor pulse oximetry in any patient who you suspect a chest wall injury, because that's probably going to be one of the earliest signs that would tell you that you have a pneumothorax in the patient or a hemothorax, is a drop in the pulse oximetry. The next thing is when you place the needle, you want to place the needle into the chest in one continuous quick motion. So what we're talking about here, if we were to needle the anterior chest, is we would locate the second intercostal space at the mid-clavicular line, and we would prep it with whatever your local protocols call for prepping the chest with, whether that's chlorhexidine, whether that's betadine. You prep that area, and then you're going to take your gloved hand and press down in between the ribs. Now, the damage that could be done to blood vessels would happen if you were to rub the needle up against the undersurface of the rib. So you want to avoid putting the needle anywhere on the undersurface of the rib. You're pressing down on the ribs to separate them, and then you're going to insert the needle in a 90-degree angle directly downward through the chest wall. The next thing that's important is to hold the needle in place once you insert it. Not remove the needle from the catheter for at least 10 to 15 seconds to allow air to be expelled from the patient's chest. So that placing the needle at a 90-degree angle in one swift motion, holding it in place after you insert it into the chest wall, are two steps that you can take to be sure that you get a better chest decompression. We're then going to take the needle out of the catheter, leave the catheter in place on the patient, and observe for some improvement in their respiratory status. Perhaps their pulse ox will improve, and you'll get a marked change in what actually has happened. Blood could come out of the needle if the patient had a hemothorax. Air could come out of the needle or the catheter that's in the chest if the patient had a pneumothorax. If the patient condition worsens, it's very likely that you would need to needle the chest again. The recommendation from trauma folks and from the military is to place a second needle at the opposite location. So you'd be on the same side of the chest, but if you had placed the initial one in the second to third intercostal space in the anterior chest, you'd then go to the lateral chest and insert a second needle in that location. So there are two locations for a needle decompression on the chest. The first is the second intercostal space at mid-clavicular line, so the clavicle running from here to here, so middle of that spot, which is on the same plateau as a nipple in most patients. And so we're mid-clavicular line, second intercostal space, so basically the first place that you can find a separation between ribs. That's the common spot for needle decompression. And then in 2012, we added a second location, which is in the fifth intercostal space, mid-axillary line. So now we're actually in between, underneath the arm, at the fifth intercostal space, which in most patients is going to be at the nipple line, coming over and using the middle of the axilla in that space. And so those two locations, fifth intercostal space, mid-axillary line, second intercostal space, mid-clavicular line. So here's another point to keep in mind when doing a needle decompression. Needles that end up medial to the location where this needle is, at the mid-clavicular line, are very likely not to be successful. So needles that are medial, closer to the inside of the mid-clavicular line than at the mid-clavicular line, are likely not to be successful. They're also likely to cause injury to structures inside the chest, the aorta on the left, the pulmonary vessels on the right, and not be successful at decompression. So you want to keep the needles at the mid-clavicular line and lateral to the mid-clavicular line, never medial to that location. The nipples serve as a reasonable landmark in most patients. Unfortunately, this mannequin is not anatomically correct, but in most patients, that mid-clavicular line is probably going to be in the same axis as the patient's nipples. So clearly this is a very low-frequency, high-risk procedure that you'd be performing. One of the important things that you can do to prepare people for this is to train with the highest fidelity simulators that you can get your hands on. So using mannequins where there's actually some realism to what you're doing, where you get some blood or you get some air out of the mannequin. You can practice inserting the needle, holding the needle in place before you remove the stylet from it. Those are all things that would help to improve your effectiveness should you actually have to do a needle decompression. Thanks for watching Fire Engineering Training Minutes. I'm Mike McEvoy. Be smart out there.